Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue the discussions about bleeding disorders in the body. In particular, when I left off last week, I was talking about a condition called ITP, idiopathic thrombocytopenic purpura, now renamed primary immune thrombocytopenia. Now, this is a quantitative platelet abnormality. A couple of weeks ago, I was talking about von Willebrand, which is a qualitative platelet abnormality. Now, 10 million folks across the world are afflicted with ITP, and in this country, some 30 million folks every year are diagnosed with ITP. Amongst them are children. The disease in children, however, almost always resolved spontaneously. Sometimes it's as a result of measles, mumps, or some upper airway viral infection, etc. But most of the time, the cause is not known. The disease itself is an autoimmune disease. Namely, an autoimmune disease is a disease that develops in the body spontaneously. For no particular reason, the body reacts against itself, and one develops a disease. And there are hundreds of such diseases throughout the world. That's just the way the body reacts. In this particular situation, the body develops an autoimmune phenomena, which then acts as an antigen, resulting in the development of an antibody to fight against this particular process, creating an antigen-antibody complex. Those complexes are now find themselves coating on top of the platelets that were normal in quality and also in quantity, and because of the covering of these complexes on top of the platelets, that now becomes a foreign substance. Those become foreign substances, and the body then have to find a way to get rid of them. That's the way the body works. And of course, the spleen plays a major role in getting rid of these platelets. So there's the liver and all the parenchymal cells throughout the body, and the reticuloendothelial cell, wherever they are, they all get together to try to fight this foreign invaders, which is basically these antigen-antibody complexes. Now, that's the science behind that. So now, how does one go about knowing if you have ITP? Most people don't know they have it until they go to see the doctor, they happen to have a blood count done, and they find that the platelet is low. And of course, there are many, many things that can cause somebody's platelet to become low, but you put ITP on top of the list. I mean, drug reactions, infections, all these things can cause somebody's platelet to go low. Chemotherapy, radiotherapy, etc., etc. Okay, now, once it is decided that it looks like ITP, because you rule out drug reaction, you rule out an infection, you rule out the person has not been receiving chemotherapy, he or she has not been receiving radiotherapy, and so you begin to narrow your search to ITP. So now, how do you go about evaluating it? Well, first of all, you take a history from the patient, you examine the patient, and you ask questions, because usually people who have ITP have easy bruising. They touch any surface, they leave a bruise right there on the skin. And they also develop petechiae, which are little punctate, reddish looking dot over the arm, over the legs, etc. We call those petechiae. We see that very, very frequently in people with ITP. Also, the patient is likely to complain about nosebleed spontaneously, bleeding from the gum, urinary, when you want to go to urinary, blood in the urine, blood in the stool, heavy vaginal bleeding for no particular other reason, etc., etc. So those things will create a reason people then will seek help from their physicians. Now, once you finish with that history and the physical exam, then of course you go about doing some laboratory testing. Well, first of all, you will do a complete blood count. Here you're looking for two things, well, actually three things in particular, really. Looking for the white count, the platelets, and the and the red cell. The white count is important because if one were to have certain malignancies such as leukemia, your white count is likely to be abnormal, and in certain leukemias or most leukemias, the platelets can be affected in one way or the other. Then the red blood cell count is important because if one has ITP and one is bleeding, then the level of red blood cell would be low. So that's the value of the red cell evaluation. Then comes the platelet. Well, the normal platelet count is from 130 to 400,000. So if one has ITP, the platelet count is likely going to be below 100,000, sometime 110,000, etc. It shouldn't be. So you have to, why is that? Okay. Then if that's all you find in the blood count, then you will automatically, at the time you're doing the blood count, you will also do a complete chemistry profile. That has major implication, because if the kidney function is abnormal, you need to pay close attention to that, because that can create issues with platelet. If the liver function tests are abnormal, you need to know that, because in cirrhosis of the liver, which I will eventually talk about one of these days in the show, that can definitely mess up the platelet count. So those are important tests to do. Then, of course, you do an HIV test. Why? Because one of the earliest presentations sometime of HIV test is low platelet count, for no particular reason, low platelet count. So that's very important to do the HIV test. Then from there, you will do what we call a platelet antibody. Now, the platelet antibody test, very important. It takes about a week or so to come back once you send it off to special laboratories, but that's very important. But even before you get to that, you would also have done a bleeding time. Remember what I said in the previous show, if you're going to do somebody's bleeding time, you want to make sure that they had not been on aspirin or NSAID. For aspirin, 7 to 10 days, and NSAID, 48 hours, etc. Because if they've been on these things, then that would mess up the bleeding time. It would cause the bleeding time to become prolonged. So that doesn't make any sense. Then, of course, as far as once you do these things, then is the patient, you also have to do an H. pylori test. Yes, I forget that. That's H. pylori. Why? Because according to the literature, 50% of folks who are infected with the H. pylori bacterium have the propensity of developing ITP. Very important to know that. Very important, because half of the world population is infected with H. pylori. 50% of the world population, believe it or not, and 70% of New York City, 30% of the U.S. population infected with H. pylori, because people travel all over the world to different places, and the sanitary situation there leave a lot to be desired, and of course they get infected to the fecal oral route, and so on and so forth. They don't actually have to travel. I have patients who have never traveled out of this country, and I diagnose them with H. pylori. You've got to keep in mind that is how important this H. pylori thing is. Here it is, I said to you, and I spoke about H. pylori in the past and on this show, and I've written it on my books, etc. Imagine 50% of the world population infected with H. pylori, and a whole lot of folks complain of chronic fatigue syndrome. Now, you probably did not know that, but you're going to find out right now that one of the most common reasons for chronic fatigue syndrome is infection by the H. pylori bacteria. How about that? So, half of the world population is infected. Millions of folks complain about chronic fatigue syndrome, which is a real syndrome. Okay, it usually occurs after Lyme disease and a whole host of other things. Now I'm telling you, H. pylori is associated with that as well. Now you can imagine the magnitude of that. We're talking about millions and billions and billions of folks have the propensity of walking around feeling tired all the time, have no energy, and they don't know what's going on. And of course, you have to test them. And it is amazing. Sometimes you shake your head after you would do the test. I mean, in order to do the H. pylori test, somebody has to have some symptom. Usually, GERD-like symptom, unexplained indigestions, etc. This feeling lousy all the time, the stomach is bloating, etc. And knowing where the patient come from, where they've visited, where they were born, where they grew up. Because you could be harboring H. pylori for 30, 40 years without knowing it. Keeping in mind, H. pylori can not only cause ITP, it can also cause cancer of the stomach. And further, it's the #1 cause of bleeding ulcers across the world. Now, here it is, I'm telling you how common H. pylori is, and it's the #1 cause of bleeding ulcers. At the same time, I'm telling you it also is associated with low platelet count. Now, can you imagine the scenario? Somebody's bleeding as a result of H. pylori. That very same person also has low platelet because of the H. pylori. The person is likely to become, to exsanguinate. That's obvious, right? Because your platelet is low and you're bleeding. The low platelet itself can cause you to bleed. And now on top of that, you're bleeding. And then some folks turns around, they have an aches and pain, they don't know what to do. They take a baby aspirin, or they take a regular aspirin, or they take an NSAID of any type. There's nothing wrong with this medication. They're great, but you can't take them if they're not appropriate for you, because you're going to create yourself a whole host of problems. You already have problem, now you're going to add to it. Okay, now, so now you come to the point now you send your platelet antibodies. I say that's going to take a while to come back, and then you're going to have to treat the patient. Now, if the platelet count is in the 100 plus, 110, 120, 90, 96, the patient has no symptom, you just leave the patient alone. You just watch them, because you tell them what to do, what not to do, and then you just watch the patients. You test them for all these things that I mentioned. There's nothing to be treated, because the patient will not bleed spontaneously unless the platelet count is below 20,000. The patient will not bleed spontaneously unless the platelet count is below 20,000. This is a known fact in the field of medicine. We know that, clinical medicine. Okay. However, if it is that you decide to treat the patient because the patient has manifested bleeding, and now you need to intervene with medication, what do? Well, one of the most common treatment, of course, is corticosteroid. Corticosteroid. How does it work? How does the steroid work? Okay. I'm not going to trouble you again, even though it's something I need to pre-point out. Now, here it is, I'm talking about steroid. It's been the #1 medication for treatment of ITP for years and years and years. And it's still being used all over the world to treat ITP. Because in this country, people have access to other medication, which I'm going to mention, but they don't have access to that throughout the world, but they have access to steroid. Now, I have mentioned many times, and I'm continue to mention, the value of this research, the creation of corticosteroid by Dr. Percy Julian, a black biochemist, an American black biochemist, who, because of racism, had to leave this country to go to Europe to get his PhD, because they won't allow him to get his PhD here. And came back, did a whole lot of stuff. The foam that people use to put out fire, that was his concoction. And on and on and on. And of course, he lived right here in Westchester. I believe in Greenberg. He died, I believe, when he was 71, 76, thereabout. Nice man, did a lot of work for the world. And his inventions, corticosteroids, still being used today all over the world, and also to treat all sorts of diseases, including ITP. Now, how does the steroid work? Well, if you give somebody with ITP steroid, I mentioned earlier the complexes of the antigen and the antibody. What we think the steroid does is that it positions itself in between the complex that contains the antigen and antibody material and prevent them from creating the reaction that they're creating that causing the lowering of the platelet. Put itself in between them, and that's how we believe that the steroid prevents this reaction from occurring, thereby allowing the platelet count to go up. Okay? All right. If it doesn't work, then they have immune globulin, intravenous immunoglobulin, we use intravenous immunoglobulin. That's another treatment. Then, more recently, we've been very successful by using a medication that we use mostly to treat lymphomas, which is Rituxan. And Rituxan works because it attacks a particular, there are many, many different subgroups of lymphocytes. Okay? And the Rituxan, because of its ability to, and these lymphocytes produce antibodies. That's where the Rituxan comes in. So these particular types of lymphocyte, the Rituxan hit it, go after it, destroy it. As the Rituxan is destroying this particular lymphocyte, which is involved in the antigen-antibody reaction, that then prevents the antibody from developing, thereby allowing the platelet count to go up. Even though Rituxan is used mostly in the treatment of lymphoma, by the way, for the same reason, not to prevent antibody production, but to destroy lymphocytes. Because when we're talking about lymphoma, we're talking about different subgroup of lymphocyte as well that's involved in this group of malignancies called lymphomas, okay? So Rituxan now becomes the #1 medication to treat ITP. Now, also another treatment that has been used over the years is to remove the patient's spleen, to do a splenectomy, to do surgery, remove the spleen. Why? Because the spleen plays a major role in the destruction of the platelet. As they are coated, the spleen is a very important organ as it relates to the immune system in the body, okay? If you don't have your spleen, you're more prone to infection, etc., etc. So, but not everybody responds to it. Some folks get positive result. Some folk wind up losing their spleen, and it didn't work. Okay, so you got a lot of folks walking around without their spleen. They still have their ITP. However, now in modern time, we are now able to go to Rituxan and try to salvage these folks by giving them Rituxan. And now there's another medication. This one is basically a platelet booster. Has nothing to do with preventing the destruction, but actually a platelet booster, something called N-plate. N, capital N plate, N-plate. Now that's a new medication that's been on the market now, approved by the FDA for the last several years, that actually increases platelet production. So the platelet is being destroyed, and you use the N-plate, and you're using the N-plate, there's nothing to prevent you also from keeping the patient on steroid or immune globulin or Rituxan or whatever, because you are really attacking the situation in 2 different ways. So you got steroid, you had IV immunoglobulin, you have Rituxan, you have splenectomy, and you have N-plate. These are the treatments that we use in modern medicine to treat individuals with ITP. But the important thing to remember, ITP can be very bad, because not only that it can cause these little other stuff that I talk about, people actually can bleed into the brain. Yeah, you could have hemorrhage into the brain and other organs in the body if your platelet count drop below. I've had patients with platelet count of 3,000, 4,000. Now that's crisis time. Crisis time. You say, well, why don't transfuse the patient with platelet? But it's just like taking gasoline and pour it on the fire. Can't do that, because the antigen-antibody reaction that's taking place in the body is hot. It's aggressive. It's going on full blast. It doesn't matter what amount of platelet you pour in there, it's going to get destroyed almost immediately. So the idea then is to try to block the reaction from occurring, thereby preventing the platelet from being coated by the antigen antibody complex, and so doing is the situation. And then you try to put the patient under bleeding protection in the hospital. Anybody with platelet that low has to be in the hospital because you have to put them on the bleeding protection. The nurses know what to do, what that means, because they're prone to bleed. Okay? I have seen adults with ITP where the disease disappeared spontaneously as well. It's not just in children, because I've seen 2 or 3 patients of mine over the years, because I remember one patient, platelet count of 2,000. That's the old St. Agnes Hospital in White Plain, bleeding from every orifice. Well, this patient is still in my practice today. We don't even talk about ITP anymore. I haven't even, we don't talk about that. Because for the last 10, 15 years, this platelet count has been normal on its own. This is a guy that I thought I was going to lose him that day. He was bleeding all over the place. Right now I'm treating him for his cholesterol and his blood pressure issue. I have not mentioned the word ITP to this gentleman in about 15 years. And he responded. That's God at work. I had nothing to do with it. I just acutely intervened, did what I had to do to save him. And of course also, as part of the treatment, you have to transfuse the patient with blood. Yes, if the patient is bleeding, they're losing a lot of red blood cells, then you have to give them blood to tie them over while you're giving a chance for your other medication to work if they're going to work. So blood transfusion, red blood cell transfusion, plays a major role in the treatment of ITP when it becomes necessary. You try to be very careful not to transfuse folks if you don't have to, but if you have to save somebody's life, because you need oxygen, because if your brain is deprived of oxygen for a matter of minutes, the damage is likely to be permanent. So you want to be very careful that you give the patient a red blood cell so that the hemoglobin that is inside the red blood cell, oxygen can attach to it so that the red blood cell carries the oxygen throughout the body. That's how it works. That's the science. So ITP is a very serious condition, and there are many, many other platelet abnormalities in the list that I presented several weeks ago that I will not be discussing with you because they are not as frequently seen, a little bit rare. They can occur, yes, they do occur, but I'm not going to take your time and deal with them. But I will, however, begin to talk to you about one more platelet condition, actually 2 more, before I move on to the coagulation part of the bleeding disorders, which I'm sure a lot of you are sitting there waiting, holding your breath, okay, as it were. All right. So let's talk a little bit then about another platelet condition. This platelet condition is called DIC, disseminated intravascular coagulopathy. DIC involves platelets because when it happens, it's consuming the platelet. It's consuming part of the coagulation pathway as well. And DIC occurs very frequently because of somebody is septic, they become infection, they have an infection, or somebody went into shock, and the shock state itself causes the secretion of certain inflammatory proteins that trigger off the whole process of creating DIC. And when you have DIC, your platelet count is quantitatively down as well. Your coagulation system is bad. Your PTT is high, your PT is high, because it's a consuming thing. The process that's going on, whatever it is, it could be an infection, it could be shock, it could be because you get bitten by a snake or some other toxin-carrying vermin or a spider, whatever, that start the process, and then you begin to consume your own coagulation material, on your platelet and you have DIC, okay, and then, when you're bleeding from DIC, you could bleed from all over the place. And they think again, how do we diagnose DIC? Well, again, you take the history from the patient. Usually, people with DIC are in the hospital. You examine them, you know they're bleeding all over the place. They have bruises all over, the bleeding from any possible orifice you can possibly imagine. And then your task is to try to save them from basically bleeding into the brain or other vital organs. And then you have to make a diagnosis. Okay, well, the diagnoses are usually made by, you do a blood count. Very, very important when you do the blood count and DIC to look at the blood smear. Because as I say, it's a consuming disease. What's happening is that the red blood cells are also being destroyed. So you have hemolysis as well. Well, when you're looking at the blood smear, you're looking for something called schistocyte, which is partly destroy red blood cell. So you look at the smear, the platelet will be very low on the blood smear, very low. And then you see the presence of schistocyte, which is half destroy red blood cell. And once you see that, then you have low platelet, you have the hemolysis, and you have abnormal coagulations, then, and you have your physical findings, then you're facing with a case of disseminated intravascular coagulopathy, which is a major, major medical problem. Major. It's a crisis. Usually these people are in the ICU or the CCU, and they are very, very, very sick. With all the other things that's happening with them, then now you have DIC. And of course, the best way to treat DIC is again to treat the underlying condition. You have to treat the underlying condition in order for you to treat DIC. I'll say a few more things about DIC next week. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.